Now today we are going to discuss a case of anemia. This is a case summary of a 56-year-old male who presented with generalized weakness, there was fatigue, and there was shortness of breath on exertion. So these were the three symptoms. He had a generalized weakness, there was fatigability, and the patient had shortness of breath on exertion. The symptom had developed over a period of last 4 to 5 months. So it was a slow onset of symptoms. He was not a diabetic, he's not a hypertensive, or he was not a smoker. On systemic inquiry, he told that he had some burning sensation in his feet. Otherwise, he had no symptoms. His weight was static. He was pale on examination with a good volume pulse of 88 per minute, a blood pressure of 110 over 70 millimeters of mercury in sitting position. And the systemic examination of this patient was almost unremarkable, except that he had absent ankle jerks. So the ankle jerks were absent on both sides. Now, we analyze these symptoms. You see, what are the positive features on clinical examination? You see, there was generalized weakness, there was fatigue, and there was shortness of breath on exertion. And there was a history of burning feet. So these were the two major symptom complex. The patient has weakness, patient has fatigability, there was shortness of breath, and there was burning sensation in the feet. And on examination, he had a generalized pallor, and there were absent ankle jerks. Then, what do you conclude from this? The patient has an anemia, and there is a neuropathy, because the absent ankle jerks indicate the patient has peripheral neuropathy. Now, we see what are the negative features which we should consider, that what could be the possible cause of all these symptoms. So the patient did not have any history of overt bleeding, that is, there was no history of rectal bleed, or there was no history of upper GI bleed, or there was no history of even a urinary bleed which was visible to the patient. So the patient did not have any overt bleeding. There were no GI or urinary symptoms. For example, patient did not have dyspeptic symptoms, or patient had diarrhea, or diarrhea alternating with constipation, or there was no history of urinary symptoms like passage of red colored urine. There were no systemic history like fever, weight loss, or there was a change in medication. There was no jaundice, or there was no edema at the time of examination. There was no lymph node enlargement. There was no hepatomegaly. There was no splenomegaly. And there were no areas of abdominal tenderness or abdominal masses palpable. And the digital examination of the rectum was normal. So these were the negative features. Patient did not have any GI or urinary symptoms. There were no systemic symptoms to suggest that the patient is having chronic disease. There was no organomegaly. Rectal examination was normal. Now, the patient has anemia and neuropathy. So what could be the possible clinical diagnosis? Clinical diagnosis could be a B12 deficiency anemia. This could be the possible clinical diagnosis. Now let's see what's our patient suffering from. You see, what are the different causes of anemia before you go into the detail of the analysis of this patient. The anemias are generally caused by substrate deficiency anemias. For example, the micronutrients may be deficient, like iron deficiency, B12 deficiency, or folic acid deficiency, or sometimes other vitamin deficiencies. And then patient may have hemolytic anemia for various reasons, and then patient may have failure of bone marrow to respond. So there may be a bone marrow failure anemia. So these are the three major reasons patient can have anemia. That is, substrate deficiency anemia, patient may have hemolytic anemia, or patient may have something which is causing trouble with the bone marrow, and bone marrow is unable to respond to anemia. Now in this patient we had a hemoglobin of 6.7. The RBC count was 4.7 million per cubic millimeters. The hematocrit was 27. The platelet counts and WBCs were slightly low. The WBCs were 3800 per cubic millimeter, and similarly the platelets were 110. The MCV was significantly low. It was 57.4 microns. And then MCHC was nearly normal. The MCHC and MCH both were nearly normal. The red cell distribution width was also normal. So this was the preliminary investigation we had. And seeing this investigation, we see the patient has anemia with disproportionately high number of RBCs. You see hemoglobin is very low, but the RBC number is not that low. Usually the RBC number is around 5 million in a normal person. It may be between 5 to 5.5 millions with a hemoglobin ranging between 12.5 to 14. So for this, almost half of the hemoglobin the patient had as compared to normal, the RBC count was not low. So there was disproportionately high RBC count. There was a very low MCV. Patient had low platelets. There was some reduction in the number of WBCs as well, while the MCHC and red cell distribution width, RDW, they were normal. Now, what could be possible? So there is a confusion. This patient has low MCV anemia. Low MCV anemia can be caused by iron deficiency anemia, but in iron deficiency anemia, the RBC count is proportionately low. It's not generally high. The MCHC is generally low and the red cell distribution width is high. So this patient has normal MCHC and normal red cell distribution width, which is against slightly the iron deficiency anemia. And then the other cause of low MCV anemia is the thalassemia trace. There is disproportionately high RBC count. There is normal MCHC and normal red cell distribution width. So could this patient have thalassemia? But you see thalassemia, they present in childhood. With such a low hemoglobin, the thalassemia could have been detected in the patient's early age. Thalassemia minor usually does not cause this low hemoglobin. The hemoglobin just remains around 9, 10 or sometimes a little over 8, but it's usually not that low that comes to 5, 6 grams. So what could then be? This is not thalassemia major. Is it thalassemia minor? Let's see further. Now, patient also has pancytopenia. Now, what is caused by pancytopenia? Pancytopenia means there is more than one cell line which is low. So this patient had low hemoglobin, the patient had low WBCs, patient had low platelets as well. So this could be because of the bone marrow failure, but in bone marrow failure, usually the MCV is normal and the red cell distribution width, that may be slightly high. Patient may have B12 deficiency anemia because the patient had evidence of neuropathy, and there is peripheral destruction. Patient may have hypersplenism, or it may be autoimmunity, whatever is the reason, patient may have peripheral destruction, and that may cause pancytopenia. But you see, the patient has low MCV, has got neuropathy. Has the patient got a composite disorder or two disorders going on in the same patient? Let's see further. What was our plan? Our plan was to do iron studies, go for hemoglobin electrophoresis, and look for the serum B12 levels. So these were conducted, and we see the iron studies was normal. The patient did not have iron deficiency anemia. The serum iron, TIBC, and in fact the transferrin saturation was also normal. The hemoglobin electrophoresis showed that there was some increase in hemoglobin A2. So this patient had beta thalassemia trait, and the B12 levels were quite low. They were less than 150. So this means the patient has B12 deficiency anemia along with beta thalassemia trait for this confusing blood picture. So the patient had most likely pernicious anemia with beta thalassemia trait because patient did not have any reason to have other causes for B12 deficiency anemia. For example, patient was not a vegan, patient did not have GI symptoms, patient otherwise was normal. So possibly it was a pernicious anemia, which can be confirmed on further testing. We can test the antibodies, and we did not actually confirm in this patient because it was not clinically important for this patient to have a confirmation of pernicious anemia. So we made a provisional diagnosis of pernicious anemia and beta thalassemia trait, and had a liaison with the patient in the future if he develops any other complications which may be associated with pernicious anemia. Since there was nothing to explain that the patient had chronic pancreatitis or patient had the ileal disease, we did not go for further investigation for pernicious anemia, and we just had a provisional presumption that the patient has pernicious anemia and there is thalassemia trait going on. So combination of this resulted in low MCV anemia with peripheral neuropathy. So when you see a patient with this sort of picture, keep in mind MCV is a calculated parameter. It depends upon hemoglobin and the hematocrit and the RBC number. So it does not give us a true picture. So when we see this sort of a picture, we should actually look at the slide, what sort of RBCs the patient is having. So this patient had a composite type of anemia. Now, what is anemia? Is reduction in either the total number of RBCs, except in thalassemias where the RBC numbers are high, otherwise the RBC numbers are low, or there is amount of hemoglobin which is reduced in circulation, or the patient has reduced circulating red cell mass. If this is present, this is called anemia, and we have got different standards for both males and females, according to which we can decide the patient is anemic or not anemic. Now, the symptoms of anemia: patient may have fatigue if there is a very severe anemia or sudden onset of anemia. Patient may have syncopal attack. There may be dyspnea. The patient may have palpitations, particularly the palpitation on exertion. And the patient may have pallor. There may be postural hypotension. There may be functional cardiac murmurs. And there may be high output cardiac failure. Now, what clues on the history which can help us making a diagnosis that this could be the possible cause of anemia? For example, if there are inherited or acquired causes, if they are present in the early childhood and there is the duration of illness, that can tell us what is the possible cause of anemia. For example, if there is a slow onset anemia, this could not be because of rapid bleed or hemolysis. Or if the patient has anemia which starts early in childhood, these may be the congenital type of anemic defect. And then severity of development of speed of development of anemia or the severity of anemia. So acute symptoms like patient has dyspnea, palpitations, there is severe fatigue, there is syncope, patient may have postural hypotension. They indicate patient has an acute onset of anemia. That may be hemolysis, or the patient may have bleed. The bleed may be visible, or sometimes may be a bleed which is internal and it's not manifested. So this may be possible. For example, in sometimes in patients who got dengue, we do not see overt manifestation. The patient may have internal bleed going on, and the patient will develop anemia. And then chronic blood loss. Patient may have abnormal menstruation. There may be repeated histories of pregnancy. Patient may have GI symptoms like dyspepsia, or patient may have diarrhea, patient may have black tarry stools, or patient may have even overt bleeding going on from hemorrhoids or ulcerative colitis or lesions like malignancies. And then the hemolytic episodes. Patients, you look for the presence of toxins, diet or family history, or there's surgery. The clue can be inherited disorders. The patient has gallbladder disease, patient has splenomegaly, or patient has splenectomy, or if the patient has splenic atrophy, or if the patient has prosthetic valves. And then you look for the presence of underlying diseases like uremia, like chronic liver disease and hypothyroidism. They may be clues to the development of anemia. Similarly, look for the associated symptoms. For example, if the patient has dysphagia, difficulty in swallowing, patient may have esophageal webs, there may be esophageal carcinoma. This usually indicates an iron deficiency anemia. Then if the patient has paresthesia, there are balance problems, there are neurological problems in this patient, this may be B12 deficiency anemia. If there are venous thrombosis, patient may have paroxysmal nocturnal hemoglobinuria, or the patient may have sickle cell disease. If the patient has severe bone pains and there are vaso-occlusive crises, this patient may be suffering from multiple myeloma, or this patient may be suffering from sickle cell disease. Then physical sign, we look into the skin as mucous membrane. Pallor may be present in any type of anemia. If the patient has jaundice, this generally indicates the patient might be having a hemolytic anemia. If there is smooth tongue, it's without papillae. This is usually indicative of pernicious anemia, but patients who have got severe iron deficiency anemia, they can also have similar type of tongue. Then there may be bruising under the skin. If there are petechial rashes, this may be aplastic anemia, indicating that a patient may have low platelets as well. And then if there are ulcers present, they may indicate sickle cell disease. And if the nails are brittle and they are spoon shaped, this patient may be suffering from iron deficiency anemia, and this condition is called koilonychia. Then look for other physical signs. If there is enlargement of the lymph nodes, this may be infectious mononucleosis, this may be lymphoma, or this may be leukemia. If the patient has cardiac dilatation, functional murmurs, and particularly if the patient has pulmonary hypertension, this may indicate sickle cell disease. The pulmonary hypertension develops in sickle cell disease, and other features can be present in any severe anemia. Patient may have splenomegaly. Splenomegaly may be mild or it may be massive. There may be hepatomegaly with splenomegaly and there is ascites. There is only hepatomegaly with there is atrophic spleen. So you may have multiple conditions which can cause. For example, patients with infectious mononucleosis may have splenomegaly. Patients who got CML, they have got massive splenomegaly. Patients who got myelofibrosis, they have got large spleens. Patients with lymphomas, leukemias, with chronic liver disease, with sickle cell disease and celiac disease, the patients tend to have smaller spleen. So sickle cell disease is one reason for anemia, and celiac disease is also one reason for iron deficiency anemia. In both these conditions, the spleen may be small, atrophied. In sickle cell disease, it is because of the sickling crisis in the spleen, which results in infarctions and fibrosis of the spleen, and it also atrophies in celiac disease. Then patient has subacute combined degeneration of the cord. There are delayed ankle reflexes. The patient may be suffering from pernicious anemia, and there may be hypothyroidism if the reflexes are hung up. And then if the patient has bony tenderness, this may be caused by hematological malignancies, this may be caused by sickle cell crisis, or it may be seen in multiple myeloma. Now let's look for an algorithm for the classification of anemia. What we see, first we define the patient has anemia on clinical features and complete blood count. And then we see what is the reticulocyte count. If the reticulocyte count index is more than 2.5, you look for either hemolysis or the hemorrhage, because the bone marrow is responding and the reticulocyte counts, they increase in both hemolysis and hemorrhage. You see, the reason may be blood loss. Blood loss may be overt. That is, for example, upper GI bleed or lower GI bleed. A patient may have urinary loss, patient may have menstrual loss. Sometimes patient may have respiratory loss, but that is not very common. So the patient may have overt blood loss, or the patient may have occult blood loss. And then patient may be seen in metabolic defects, may be seen in membrane defects of the RBCs, it may be seen in hemoglobinopathies, there may be autoimmune destruction, and there may be fragmentation hemolysis. Fragmentation hemolysis is that the RBCs, they are broken down in circulation because of mechanical problems, for example, prosthetic valves, or very severe accelerated hypertension, or in disseminated intravascular coagulopathy, patient may have fragmentation hemolysis. And then if the reticulocyte index is low, it is less than 2.5, look for the red cell morphology. Is the red cell morphology microcytic or it is macrocytic cells, smaller cells or the larger cells? So these are usually maturation defects when the RBC morphology shows micro or macrocytics. If there are nuclear defects, patient have larger cells, for example, folic acid deficiency, there's B12 deficiency, some of the drugs and refractory anemias can have larger cells, for example, myelodysplasia. And then if the patient has cytoplasmic defects, these are usually smaller RBCs, for example, iron deficiency anemia, it may be because of thalassemias, or maybe because of the sideroblastic anemias. And you see, if there is normocytic and normochromic type of picture, this may be hypofunctioning of the bone marrow. So that may be seen in marrow disease like infiltration, fibrosis, or there is aplasia. So the reason of marrow damage may be infiltration, this may be fibrosis, or there may be agenesis or aplasia. And then it may be seen in iron deficiency anemia, and sometimes you see decreased stimulation. For example, there is chronic inflammation going on, there may be metabolic diseases like renal failure. So these patients may have hypofunctioning of the bone marrow because of these inflammatory or metabolic diseases. And then classification based on red cell size and red cell distribution width. You see, we see cell size, the red cell distribution, it's normal or it is high. So red cell distribution width and cell size. We see patient have microcytes. The MCV is low, it's less than 70. Then with normal red cell distribution width, if the red cell distribution width is normal, this may be caused by thalassemia minor, it may be caused by anemia of chronic disease, it may also be caused by some of the hemoglobinopathy traits. So you may see a normal red cell distribution width, while you see high red cell distribution width with low MCV. It may be seen in iron deficiency anemia, in hemoglobin H disease, anemia of chronic disease, and some of the thalassemia minor cases, and it may be seen in fragmentation hemolysis. So the red cell distribution may be high, the RBC size may be small. When you have got normocytes, the red cell distribution width is normal. In the previous we saw the microcytes. Now we see the normocytes. Those normocytes in which the normal red cell distribution width is seen. Maybe anemia of chronic disease, it may be in the spherocytosis, it may be acute bleeding, and some of the hemoglobinopathy traits. You may have normocytes with normal red cell distribution width, and then you can have normocytes with high red cell distribution width. For example, patients who have early or partially treated iron deficiency anemia. When the iron deficiency anemia is treated, the reticulocytes and other slightly immature cells, they start coming into the circulation, which are larger in size. So the red cell distribution width starts increasing. It may be seen in other vitamin deficiencies, or sometimes it is also seen in sickle cell disease. And then if you have got macrocytes, that is the MCV is more than 100, then patients who've got normal red cell distribution width, it may be seen in those patients who've got aplastic anemia or those who've got myelodysplastic syndromes. In patients who've got normal, who've got high MCV and they've got normal red cell distribution width, it may be seen in B12 deficiency anemia or folic acid deficiency anemia, or sometime in autoimmune hemolytic anemias, cold agglutinin disease, myelodysplastic syndromes, liver disease, thyroid disease, and alcohol. So the patient may have macrocytosis with high red cell distribution width. And if you see the smear and see abnormal RBC morphology, then what do you see? You see if there is sickling and target cell, this is hemoglobin SS disease, there may be hemoglobin S disease, or it may be thalassemia. If the patient has target cell and stippling, this is thalassemia minor. So if the target cells and stippling is present, this is thalassemia minor. If there is sickling and target cell present, this is usually sickle cell disease. If the patient has many target cells, it may be in the hemoglobin E disease, hemoglobin C disease, or sometimes in obstructive liver disease. If the patient has RBC fragment on the slide, this is hemolysis. And if there is Rollier formation, this is usually because of high globulins and low albumin, which is usually seen in cases of multiple myeloma. If the smear is non-diagnostic, if you see the smear, you cannot make a judgment what is the possible cause. What we do is we go for the red cell distribution width. You see, if there is a high red cell distribution width, that is more than 16, so it's usually iron deficiency anemia. And if we consider iron deficiency anemia, we go for ferritin level. If the ferritin level is low, this is usually iron deficiency anemia. And if we need to further confirm, we can go for serum iron levels and TIBC, and we can calculate transferrin saturation. If it is low, this is iron deficiency anemia. If the ferritin level is non-diagnostic, go for TIBC. And if ferritin level is high, examine the bone marrow. There may be sideroblastic anemia, there may be marrow failure. So if you've got, considering the iron deficiency anemia and your ferritin levels are very high, examine the bone marrow. Look for the sideroblastic anemia, and there may be marrow failure anemias. If the smear review is non-diagnostic, go for red cell distribution width. If there is normal red cell distribution width, you see in the last slide we discussed those who have got higher red cell distribution width. We go for a lower or normal red cell distribution width. What we see, we go for RBC count. If there is RBC count is low, then this is probably anemia of chronic disease. Maybe testing for underlying disease may be important. For go for iron, ferritin, and RBC morphology. That may be useful, but you can go for underlying conditions. For example, patient may be having renal failure, or patient may be having chronic inflammatory disease. And then if the RBC count is normal or RBC number is high. This is usually early iron deficiency anemia, or this is thalassemia, and sometimes maybe because of other abnormal hemoglobins. So we can go for hemoglobin A2 level for considering the diagnosis of thalassemia trace. If this hemoglobin A2 is more than 4%, this is possibly a thalassemia trait, and if the patient has hemoglobin A2 level is less than 4%, look for hemoglobin analysis that there may be other variants of hemoglobin which are causing anemia. And then you see macrocytic anemia. If the patient presents with macrocytic anemia, you can use the reticulocyte count for assessing what could be the possible cause of this anemia. You see, there is macrocytic anemia, you go for reticulocyte count. If the reticulocyte count is increased, this may be hemolysis, this may be hemorrhage, this may be treated B12 or folic acid deficiency. Patients got normal or decreased reticulocyte count and they have larger cells. You see, if the large cells are round or oval macrocytes. If there are round macrocytes, there is associated hypersegmentation in the neutrophils present or not present. So go for a bone marrow examination. Bone marrow examination, this shows a megaloblastic change. This is B12 or folic acid deficiency anemia. So we can go for serum B12 and folic acid levels. Folic acid level can be done in serum and can be done in red cell as well. Red cell folate is offered by a few labs. It's not generally available. So generally we go for a serum folic acid level. And you see, if the bone marrow examination does not show a megaloblastic change, in fact it shows us a normoblastic change in that. So the patient may be suffering from alcohol, patient might have taken some drugs which are causing anemia, it is chronic liver disease, thyroid disease. There may be aplastic anemia, or patient may have myelofibrosis, or patient may have myelodysplastic syndromes. So this is how we go in patients who present with the different type of anemias, and we can, you see, assess the anemia based on RBC count, the red cell distribution width, the size of the RBCs. So all these can be used to assess the type of anemia patient has, and out of this the most important is the reticulocyte index. Patient has a high reticulocyte index or low reticulocyte index, and then we can further proceed what could be the possible cause of this patient's anemia.